Okay, I think we're ready to go.
Okay. All right. Thank you, Bruce. Good afternoon, everyone. My name is John Paul Kroom. I am the president of the Georgia chapter of ACHE this year. I'm thankful for all of you who are able to join us this afternoon. We have a wonderful program, one that I think many of you will be very interested in. Before we get started with our program or our webinar, which is entitled How to Improve Physician-Administrator Relationships, I would like to make a few announcements and thank our sponsors. First, let me express gratitude to our platinum sponsors, Atrium Health Navicent, Grady Healthcare, Kaiser Permanente, Moss Adams, and Wellstar Health System. Also, our gold sponsors, Act Talent, Grant Thornton, Healthcare Program Advisors, Piedmont Healthcare, Northeast Georgia Health System, and Visia Technologies. And finally, our silver sponsors, thanks to DT Spade, Georgia Nurses Association, KCA Firm, Metro Atlanta Ambulance Service, Premier Federal, SSR Inc., and Viblio Health. Our meetings are displayed here on your screen, and our highlights include we are meeting in person on November 7th at Maggiano's for our Lunch and Learn and annual business meeting, where we will elect our 2025 board slate. And be sure to join us for our annual joint holiday event with Georgia Hymns on December 5th at Lake Lanier Islands. We had a great turnout last year, and I hope that many of you will return this year. Visit our events page at www.acheofgeorgia.org for details and registration. To encourage members to take the Board of Governors exam, our fellow advancement committee is offering an online archive of last fall's prep class for $50. Look for details on our home page. Stay connected with ACHE of Georgia by following our social media pages. Visit our website for more information. We'd also like to invite you to get involved by serving on one of our many ACHE of Georgia committees. Contact ACHE of Georgia or go through our website for more information. Today's program offers 1 hour of ACHE qualifying education credit. Our topic today is how to improve physician-administrator relationships. And now it is my pleasure to introduce our speaker, Dr. Marzena Buzanowska, MD and MHA. Dr. Buzanowska is an interventional spine and musculoskeletal medicine physician and a medical director at River City Sports and Spine Specialist in Columbus, Georgia. She is founder of Leadership Breakthroughs Academy, a leadership coaching and consulting organization. She is also the assistant professor of medicine and director of musculoskeletal medicine and interventional spine fellowship. Prior to joining River City, Dr. Buzanowska spent 4 years at the Cleveland Clinic. Dr. Buzanowska has been a speaker for national meetings and has published articles, abstracts, and book chapters on the topics of interventional spine and regenerative medicine, musculoskeletal conditions, as well as healthcare leadership, implicit bias, effective teamwork with diverse groups, and conflict management. She is a member of multiple professional societies where she is active in the sphere of healthcare leadership, legislation, and health policy. At this time, it is my pleasure to turn the meeting over to Dr. Buzanowska.
Thank you so much for allowing me to be here, and thank you for this wonderful introduction. Going to go ahead and share my slides. Okay. So it is really my pleasure to be here today and talk about the doctor-administrator relationship. This whole topic has become one of my big interests throughout my career as I've progressed through academic medicine, hospital medicine, being in private practice. So I'm excited to share some of my thoughts with you. And what we're gonna cover today is kind of gonna be in these four broad categories. We're gonna talk about the healthcare executives and administrators in general as a team in healthcare systems. We're gonna and see if they're happy and what's their role and what they're thinking about. Then we're gonna do the same with regards to physicians, and then we're gonna touch a little bit on why are they in conflict and what is their conflict all about. And then we'll talk a little bit about how to bridge that gap. But I think those solutions are gonna come to you individually as we go through the background of this topic. So let's start with the healthcare leaders. And to set the tone for this conversation, I wanted to really understand and let it sink in that leaders and healthcare leaders and executives is the group of individuals in health systems that's truly are responsible and in charge of setting the directions of the institutions, which includes all the standards, regulations, as well as tone and culture of their teams and organizations. And what's mainly on their minds and what they're focusing on in their daily work is managing resources to a large extent. And they have a huge responsibility on their shoulders to the regulatory bodies to keep the hospitals credentialed and able to function. They're responsible to the community to make sure the hospitals are operational and continue in the long term serving the public. They're responsible to the staff and people who work within the hospitals, also to the board of directors and many other stakeholders, essentially for everything for operational and functional within the organizations and for the overall existence of the organization, long-term sustainability. So it's a huge responsibility on their shoulders. So given the burden of that, we talk a lot about burnout in different professional groups, but I think we haven't really focused that much on burnout within the healthcare executive team. And there's been a few studies on this, one done by Whitkeefer, where they surveyed 343 CEOs, CFOs, executive officers, and other senior executives about burnout. And what they found, and that's 2022, so kind of exiting the pandemic or middle towards the end of the pandemic. And what they found was that 75% of healthcare executives know colleagues who left healthcare due to burnout. 51% say that burnout caused them to leave their positions, could cause them to leave their positions. So about half. 50% say that burnout could cause them to look for positions completely outside of healthcare. And that impacts them individually, personally in other ways. So 65% of healthcare leaders say that they never, rarely or never take their allotted vacations. They aren't getting 7 to 8 hours of sleep. 47% say that burnout had negative impact on their personal relationships. And 46% say that they frequently skip at least one meal a day because they're too busy or stressed out. So that's one of the ways to look at how the burden and the responsibility is affecting the healthcare executives and the stress and toll it takes on them. 2021 ACHE survey of 1,200 members with only 22% response rate also reported that about half of executives report high range of burnout. But somewhat reassuringly, 88% agreed that they still like or strongly agree that they like their job. And a little bit over half healthcare leaders scored in a high range on professional fulfillment index. So to some extent, those challenges might be difficult, and but at least half of leaders still feel that they enjoy their jobs. And when it comes to the causes of their stress are obviously related to their responsibilities, and their jobs have gotten a lot harder in the last decade. And that includes the tightening of margins, recently even more stress related to workforce pressures and supply chain disruptions, and of course the increasing regulatory oversight and requirements. To keep the organizations going and sustainable. And this is the kind of stuff that we as physicians don't have to think about. So Whitkiefer went further and asked the executives what they would like to do or what they recommend to reduce burnout. And what they said is that 26% wanted more efficient teamwork, reduction of workload, more reasonable expectations for deadlines, and so on. And then about 30% also reported that they wanted more autonomy in these highly matrixed organizations. They want to feel more supported by their leaders, especially when things get tough. They want to have a strategic focus and say no to, so more, again, goes a little bit further with autonomy, improved alignment on top priorities. Okay, so this is very interesting, and because when we talk to doctors about what they want from organizations to improve their satisfaction and reduce burnout, these very similar themes come up as well. So let's turn our focus to physicians. Let's see what their world looks like, or our world looks like, I should say, since I'm one of them. So instead of focusing on managing resources, we focus on the patient, entirely and solely on the patient. And we are ultimately responsible for carrying out the mission and the purpose of existence of healthcare institutions. We are the people who carry out that work. And both in practical terms by doing the work, but also in legal terms. We are also the ones responsible legally for the care of the patient. So while administrators are responsible to the board of directors, public regulatory bodies, in legal terms, we are responsible also for the care of the patient. So when we feel report our concerns about autonomy and decision-making, it has direct line of responsibility and accountability legally for what we do. And unfortunately, the burnout statistics don't look much better for doctors. A study from AMA from last year reported that 40% of doctors exit within the next 2 years. And a lot of them are also looking for non-healthcare careers. A study from, again, last year, AMA reported that 48% of physicians experience burnout, and the cost of that is very high. So I'm seeing a lot of connections here to some of the stresses on the shoulders of executives related to the challenges that doctors are also reporting, because burnout among physicians is extremely costly. And if a lot of them want to leave, that puts further strains on the workforce. And a topic that's a little bit more difficult to discuss, but out there as well, is that burnout is associated with depression and suicide among doctors. Some statistics say that could be up to even one physician a day choosing to end their lives because of depression and burnout related to that. So yeah, so it can get pretty tough. And so how did we arrive here? When we look at the changing landscape of healthcare organizations, one trend that's very clear is that between 1975 and 2010, the number of physicians grew by 150%, which is about proportional to the population growth. But the number of healthcare administrators increased by 3,200%. So according to some statistics, that makes it a ratio of 10 administrators to 1 doctor. Which the time frame also shows correlations between increase in burnout and conflict. In a lot of those rules and procedures and regulations that administrators are focusing on fall on the laps and hands of physicians to carry out. Okay, so now we have so many more people governing everything that we do. It becomes quite overwhelming at times. So when physicians report what drives their burnout and dissatisfaction, we can kind of divide it into 2 categories. One related to the culture of medicine, and the other to the actual practice of medicine. And when it comes to the culture, the most common complaints are related to loss of autonomy and control over our lives, our schedules, locations, our practice, breakdown of community, the perceived absence of fairness, and then conflicting values between us and other leaders and healthcare leaders, in particular, feeling like organizations are run like a business and losing connection with what's important to us in our daily lives and mission. And then related to the practice of medicine, we feel there's an ever-increasing administrative burdens and hassles, inadequate support in practices and health systems to mitigate these obstacles. So things related to prior authorizations, EMR systems, and things like that. Some of the burnout and dissatisfaction comes from what we see as deliberate disinformation campaigns and political attacks on medical science and physicians as a group. And then third-party interference in patient-physician relationship. So healthcare systems have, again, changed significantly over the last few decades from a model that historically has been very much physician-centric to a very complex, matrixed, multidisciplinary, and very highly interdependent collaborative teams. It's the complexity of things that we do today requires huge teams sometimes, and a lot of people from very diverse backgrounds. In high quality because we do such complex things, so we talked about stroke, we talked about right before this call, hospitals taking care of stroke patients. When you think about what was done for stroke patients even 10 years ago, was so much less complicated than what we are able to offer now. But to do what we do now requires so many different people in just large teams of very highly specialized and experts. And so as we are now functioning in these multidisciplinary interdependent teams, over 50% of doctors perceive that there's conflict in their working relationships with hospital management. And those management problems are the #1 reason for leaving a job. So So this is what we say about each other. Physicians feel that administrators don't care or understand the challenges that we are facing while taking care of patients, and that we're treated as line workers with little control of our schedules in support teams or even clinical decision-making. And administrators, on the other hand, feel that we don't understand the challenges that they face daily of running complex organizations, including the financial, the management challenges, and the ongoing regulatory and market pressures that we don't have to think about. We can hopefully just benefit from having all of that in place. So this is a study from Northwestern where they looked at, they surveyed 20 physicians and 20 administrators at a time when there was a merger between a physician group and a hospital system, and asked them about the relationship between the physicians and administrators. And not surprisingly, what they found was that 90% of both doctors and administrators reported difficulties in connecting and collaborating with the other professional group. The issues that they both agreed upon that were problems was lack of transparency, ineffective meetings, lack of effective physician leaders that had negative impact on the physician practices. And again, those things related to autonomy and support systems, such as what happened with centralized scheduling and so on. In the other, what they've observed from this study was that the further removed a member of a professional group was, the more negative they were towards the member of the other group, and the more they stereotype the behavior of the other group. And what they concluded was that what was truly and ultimately at the core of this conflict was cultural issues that related to professional backgrounds, values, and ways of thinking. So physicians and administrators live and represent completely different cultures, okay? Even though we agree on our values, our core values of honesty, loyalty, humility, and so on, we have completely different educational backgrounds and different cultures where we live. So to name some of those differences, administrators tend to have a significantly more diverse cultural and educational background compared to physicians who essentially train within their group. And not just a physician group as a large whole, but we intensely socialize and train and learn what we do through almost like a apprenticeship practice, where we are very closely working with those from our own specialty, and are evaluated and get feedback and develop very close relationships with those within our own specialty, not even across medical specialties. And so our loyalty goes to those from our own specialty and departments, while identity and loyalty of administrator goes to the institution. As far as goals of administrators, they want to advance the brand, they want to grow the institution, organization, while physicians' goals is excellent care and to advance their profession and their specialty. Physicians tend to think in shorter time spans, so minutes to days. What we do in our daily lives has impact within days, sometimes longer than that, sometimes weeks. Sometimes we look at long-term outcomes, but really, for the most part, what we do has an impact within days, sometimes even minutes if you're in the ICU or inpatient setting. But for administrators, they think in weeks to years, and they have a different problem-solving mindset. They distill information into multiple options, but physicians have to make decisions quickly, and they have to come into one final decision and take action on that. And there's oftentimes there's very high pressure to be right in an uncertain environment. You have to be right with one decision. You only have one way to go. And we focus on our own individual and legacy and within our specialty and within our own specialty. While administrators look at their career growth and vertical ascension within the team for themselves. So a lot of differences. Our worlds really don't overlap very much, except when we're in conflict, except when we're stepping on each other's toes. So why is it so when we both feel that we want the same things? We all want more, we both want more autonomy, we want more support, and we significantly depend on each other for success of organization, that we claim the success of is in both of our interests and our core value. So why are we struggling with that? And the answer to that is in social identity theory. And what it is that humans have a powerful tendency to form social groups of like-minded individuals, and they want to differentiate themselves from others. And once you take on identity of one group, you think more highly of your own group, and you also, we also tend to think that people who belong to our groups are more sophisticated, they're more diverse and nuanced, while we just based on psychological behavior, we tend to stereotype those from other groups and brush them with a paint them with a broad brush. And the more disconnection, the more separateness, the less overlap, the more stereotyping, less trust. So when we're forced to work together in these disconnected ways, and one of us feels threatened in any way, there's going to be conflict. So in the study from Northwestern, essentially all the most or 90% of the participants offered solutions related to increasing communication, transparency, aligning incentives, and spending more time in each other's worlds, with the goal of increasing positive interactions and trust between each other. And they all agree that this can only be done through high-level effective leadership. And this is the power of strong, enlightened, high-level leadership. With high-level leadership skills, you really can achieve almost anything. And the reassuring thing and the exciting thing is that what they found is that even small improvements in leadership are shown to significantly improve the collaboration and satisfaction of both groups and reduce burnout. So how can we do this? How can we align physicians and leaders? So I think that most of you, if you were asked this question, you would probably answer it very easily, and your answers would likely look like what I have here, related to creating a common vision, patient-centered vision, one that any diverse group within the hospital system can easily subscribe to. We need to build more positive relationships with each other. And that can be done through increasing contact and understanding each other's roles, of course, because again, based on the social identity theory, the more disconnected the two different groups are, the more conflict, the more stereotyping, the less trust there's going to be. And all of those things are related to conflict. So we have to spend time in each other's worlds, and we have to really develop positive relationships and educate each other on what we do and the stress of what we do. And through that, we have to build trust through transparency and communication. And preservation of physician autonomy when it comes to physician leaders, and of course, leaders want also their autonomy in their own relationships with their higher level or people higher above them in the leadership structure. So I guess I really have not come up with anything too exciting here. I said, let's create a vision, let's build relationships and understand each other more, but build trust, better communication. I think we all knew that we need to do this, and we are probably all already doing a lot of this. My impression is that if I ask any CEO or CMO, are you creating a vision? Are you building relationships and trust? And they're gonna be saying like, yeah, we're doing this every day. That's majority of our focus on when it comes to developing culture in how we interact with each other. And yet we're having all these problems, still having a conflict, and we're still disconnected and unhappy, and all this burnout and people leaving, and we don't even care anymore. Some might probably feel. So why is this not enough, or where are we not getting this? I'd be curious to hear your thoughts, but I'm going to share what I think. And what I think is at the core of why this is not working, or not working enough, or as much as we really need it to work, because again, we're half of us and half of leaders are burned out and unhappy, and we feel like and half of us feel like there's constant conflict. So it's in our interest to resolve this. So the biggest reason why the social identity theory, what they report is that is lacking between two groups that have different identities, is that there's lack of trust. So the reason why people form groups is because they feel that they need to be in a circle of people that they can trust and they feel safe with. Okay, so people you know better, people you relate to in some way, you feel like you have a shared experience with them, there's a level of instant, deep, unconscious trust you have for those people. But when you start to identify someone else as belonging to a different group that's different than yours, you don't identify with that group, what you lose most importantly is trust. So when we focus on activities that are with the aim of improving relationships with each other, the spending time in each other's worlds and getting to know what we do and having a shared vision, if those things don't really lead to trust, then you're not really achieving your goals. You can be doing those things and feel like you're doing what you should be doing, but if really you're not building trust through those activities, then you're not achieving your goals. So the question is, do you think that what you do, the the things you implement to bridge the gap between these two groups, do you think the other person will, or the other group will develop more trust with you after engaging in those activities or not? If the answer is I'm not sure, that means that probably your intentions are not 100% in line with what you claim you want to achieve. So having a CMO or having a token physician involved in projects and decision making, and strategic decision making and planning may make you feel like you're involving physicians, but they might not feel like this is honest. This doesn't really help them build more trust with administrators. So now, on the other hand, what was also clear is that leadership training is very important. Understanding how to interact with each other and understanding these psychological dynamics in order to be stronger leaders and truly be able to influence and collaborate effectively requires leadership training really on both sides. Definitely for physicians, because that's something that we do not get any education in our formal education, medical education on. But same really goes for administrators. You know, they're also part of those conflicts. And in order to really have sustainable systems that trust is almost built into the culture, there has to be accountability towards each other on both sides. So when we have peer reviews for physicians who don't follow certain rules or step out of line, a similar accountability process has to be available and present also for administrators. And leadership training becomes very important because when things don't work, when we have pressures, and healthcare is a very high stress, high pressure environment where we are already walking tight margins, but we literally cannot afford wrong decisions. And when we have all of that on our shoulders and already living with burnout and not sleeping, not eating, it's very easy to respond to conflict with a in the control and power dynamic type of way, instead of with curiosity and see how we can align and work together. And the more you go into this power struggle, the worse things are, of course, going to get. So essentially, we know that in modern healthcare institutions, collaboration is not only the right choice, the best choice, but it's also crucial. It's also the only way, really. So we all know that we know it's to the benefit of everyone involved to do it. What stops us? It is the underlying psychological dynamic. And that is something that we can learn to overcome. And yeah, and prevent a lot of conflict and issues. So there's a lot more that we can talk about, but I would like to leave some time for questions, and yeah, welcome any questions from you.
A lot to think, a lot to unpack there. Marzena, a lot to unpack, a lot of questions that that I have throughout this conversation. Marlene Siden checks in with this question, and I think this is a really great way to start the Q&A. Has there ever been studies or findings on better relationships and less burnout between administration and physicians when there are physicians in the executive role? That's a growing trend. There's a lot, and Dr. Buzanowska, there's a growing trend where more physicians are moving into leadership roles, and they're taking on kind of that COO, now CEO role, moving away from just being a physician officer. What are your thoughts on? Has there been any study around improvement in the relationship, improvement in burnout, improvement in the areas that you've talked about when the CEO is also a physician?
Yeah, and I have thought about that quite a bit. There is some literature that says that healthcare systems that are run by physicians do somewhat better. And there's also more physician satisfaction in those hospitals and systems. And I worked in a place like that. And I worked in places that were not like that. And I can tell you that from a cultural perspective, from the overall dynamic, for physicians, there's a world of difference, and it's feels so much better to be in a hospital that's run by physicians. But there can also be some challenges, because when those physician leaders and administrators almost lose their kind of physician mindset and lose their connection, it can be sort of like in the name only. They represent the physicians, but they really, again, take on and completely like a businessman approach to running the healthcare institution. And it can be very hard in those situations to have almost someone to go to, right? It creates this environment where it feels like, okay, well, you have a doctor, so like they understand what you're going through, why, and you're still not happy, then like maybe you're the problem. So it almost, but when you have systems where they're distinct, then you can maybe, it becomes a little bit more clear where the problems are, if that makes sense. So it becomes very hard when the physician leaders completely lose that physician mindset and background, and take on, embody all the behaviors that we may not like in some administrators. And then it makes it feel like, there's nothing else to do and nowhere else to go.
Yeah, I think we've seen that also in nursing leadership, where nurses have matriculated to charge nurse and then nurse manager and director and moved up, and then became the chief nursing, throughout their career, moved up to chief nursing executive role, and they have to take on that executive role, that leadership decision making role. And some of the subordinate nurses have that same situation. You're like, well, you're a nurse. Why are you not always, 100% advocating for us all the time? I can see that also playing out in terms of a chief medical officer or not, excuse me, a CEO that was also a physician, where there's this idea where you're not 100% advocating for us. And we have to keep in mind that the executive is also having to look after the fiduciary and the responsibilities of the organization and the mission. Amanda asked a very similar question about to Marlene's question: when physicians take the lead and become the physician executive, is conflict reduced, and I think, and trust improved, and you hit on that. Amanda, I'd love for you to unmute and maybe kind of build on that question a little bit, maybe add something to that.
Sure. This is such a good presentation, by the way. Sure wish I'd heard this decades ago when I was getting into hospital administration. I think administrators oftentimes are believing that partnerships with their physicians should just be a natural thing. And this lends some really great insight into how those should not be taken for granted. Partnership just doesn't happen automatically between the administrator, who is technically trained as a business person, and the physician or clinician leader who are trained to take care of patients. So it's not an additional question, it's just an additional insight. And I think this is really, really valuable. And I guess maybe what I would ask is, what are additional concrete things that administrators and physicians can do to come together for the sake of the organization and the patients that they care for together?
Yeah, thank you so much, Amanda, for bringing this up, because I purposefully did not list more specific things because it is very much dependent on your particular organization, department, team. You need to assess the situation, diagnose the problem for your own team. Those specific interventions are gonna be very individualized. So, while for maybe some groups or teams, it's going to be about talking about, what are the regulatory burdens or what are the documentation burdens. For another group, it might be scheduling vacation. One big insult that I think a lot of physicians feel is we have to request vacation 90 days in advance, or if something comes up, you cannot with any last minute changes, we feel like we're treated like kindergartners, and have to ask for permission every step of the way. So those things that help us understand each other, those resentments are going to be very specific to each team and each group. And you have to take that due diligence of diagnosing and assessing your own department and situation. And through those, I think the theme that comes up consistently is, which is very hard when you have people who are somewhat antagonistic against each other and have stereotypical views of each other. It's very hard to come to that group, taking off the feelings of threat, feelings of antagonism, and really going in and having an open mind and respect for the people that you just stereotype, you kind of in some ways maybe dehumanize a little bit, and go in and really with full respect listening to them and take their grudges seriously, because you just stereotyped why they're complaining, right? And now to take it seriously almost goes against everything that you've taught. So, but that is the first step.
Great question.
That's great.
Yeah, great question, Amanda. Oh, sorry, I didn't mean to interrupt you. Thank you. Great question there, Amanda. And I think that's a really important discussion to have. Jack Sauls has a question. And this is an interesting question. This might be the $64,000 question, if you will. As physicians are being asked to participate in health system related administrative activities, should they be compensated for this time? And that might be a can of worms we probably ought to open on a whole different discussion platform. But what are your thoughts about that, Dr. Buzanowska? As organizations are asking leaders, physicians to step up into leadership roles, be it formal or informal, how should they manage that from a compensation perspective?
Well, I guess I'm gonna ask you, would you take on more responsibilities for free when you're already burnt out and asked to do more than you feel you can handle sometimes, when you're not sleeping, when you're not eating? Would you want to do more free work? You've spent all this time. I mean, it just doesn't make sense to ask highly trained professionals who get compensated for seeing patients to do free work. I mean, I think it's almost a little bit disrespectful to do that.
Yeah, I think that, and I think that's a good point to talk about from a perspective of your concept of social identity theory, that would drive a wedge between us and them
Yeah,
even
because you get
further.
paid for administrative, your
Yeah,
administrative
exactly.
work.
Yeah.
I mean, I know where of situations where the doctors would leave for maternity or paternity leave, and they come back to work and they say, we're going to reduce your salary because you didn't meet your IVU requirements. I mean, you know, so.
Yeah, great answer. Craig McEwen's got a question. Craig, would you like to unmute and then ask your question directly?
Yes, thank you so much for allowing me to ask my question. Excellent presentation, Dr. Buzanowska. What my question is that what are some of the tools and techniques and or experiences that you can share regarding the navigating of the relationships, connecting and collaborating with healthcare executives regarding the lack of transparency and a doctor's perception of lack of autonomy in healthcare settings?
Tools to navigate relationships with physicians regarding their perception of lack of autonomy.
Right. And lack of transparency that you mentioned in your presentation.
Yeah. And I think transparency is a tricky one because some of the things you really cannot divulge to the general public, right? That you're dealing with some of the information you have. I think that one of the biggest, most important skills in that arena is developing trust and integrity in who you are as a leader. So you may not have to explain everything with regards to all the difficult decisions that you have to make that affect physicians and really everyone else, but talking about physicians here. So you may not always have to explain everything, but if you have developed a relationship, a positive relationship with that group of professionals, and you develop that trust, you're not going to have to explain everything all the time.
Okay.
Yeah.
Thank you. Yeah,
I
thank you for that
also had a
question,
really
Craig.
quick follow-up question too, because I was very intrigued by your presentation. This is a very interesting subject. So how would you mitigate administrative and physician cultural differences that you mentioned earlier or in the latter part of your presentation as well, which I thought was a fascinating insight because you talked about how administrative and physician differences not only are cultural, but a lot of times they're educational as well. And how would you mitigate those cultural differences that you shared with us on that?
Yeah. There's a lot of literature on this in different settings. So physician administrator setting is one setting. When you look at other situations where you have people from different cultures and how they get them to work together smoothly and get them to highly perform. And what becomes important is that each group wants to preserve their identity. So the best, most highly performing groups are where each group feels seen and respected within their own identity, and you have a strong shared identity. Okay, so this is why there's so much emphasis on shared values and really clear mission that unites us all. So you can have one shared identity as, you know, two pillars of the institution, which is the healthcare leaders and physicians. Without leaders, we don't have the infrastructures to work in. Without physicians, you don't need the infrastructure. We don't exist, right? We cannot do anything. So we represent the two important pillars of the institution, and we have to develop a shared mission that we feel unites us. We need to develop shared experiences that make us feel and believe and trust this mission. and preserve our individual identities in a respectful way. Okay, so we want to feel valued and respected for who we are without needing to become you. And so, and the same for you.
Thank you.
Great follow up there, Craig. And to your point, Dr. Buzanowska, you've taught about social identity theory. Robert Cialdini's work on influence, he updated it. His 6 principles of influence, a lot of us have followed and very familiar with. He updated it during the pandemic and re-released the book in his seminal work around influence, and he added a 7th principle, and that principle is the principle of unity. And all the things you just talked about was this shared experience and being able to see each other as the same and having a shared experience. I'm really curious around that discussion. But Amanda, you have a follow-up question. I'd love for you to unmute. I'm sorry, I wanted to talk about Cialdini, but it really fits with what we're talking about. Amanda, your follow-up.
Yeah, sure. Thanks, Marion. So I love the observations and insights about engaging physicians on the front lines, which is so important. Can you tell us more about your perspective on this? Because in my experience, when both administrators and/or physician executives become too far removed from the front lines, resentments increase and trust erodes.
How to engage administrators and physicians?
Well, folks, the whole perspective of paying attention to folks on the front lines, engaging physicians on the front lines, whether you're an administrator trying to do it or even a physician executive, because I see as folks rise in the organization, whether they're administrators or they're physician administrators, if they're too far removed from those front lines,
Yeah.
then you've got a problem. And so
Yeah.
just comment on that a little bit more.
Yeah, I mean, you just have to step in those people's shoes. You have to be
Yeah.
present. You have to be seen. You have to go and do the work without offering solutions, without going and trying to comment and fix things. Just step in their shoes, and then that's the first step in building trust with them. And then just listen. It's like any other time, right? It's all about listening. But if you first spend some time in their shoes and you get to feel what they experience, the stress, the drama, the pain, all the things that go on being a frontline physician or nurse or whoever that is, and then you get and go and ask them, you will have a receptive and more honest discussion about it.
That's a great place for us to wrap up. It's time to wrap it up from Bruce. So Dr. Buzanowska, on behalf of the programs committee for what used to be GAHI, the Georgia Association of Healthcare Executives, now the Association of Healthcare Executives of Georgia. I get it. JP, I'm never going to get that right. I'm going to go the rest of my life calling it the wrong name.
That's all right.
We want to thank you, Dr. Buzanowska. I'll hand it off to you, JP.
All right. Thank you so much, Marion. Yes, it's always tough when we change a name, but the next generation will get used to it. So thank you again, Dr. Buzanowski, for today's webinar, and to Marion Spears-Carr for moderating the Q&A session. Thank you again to our sponsors. We appreciate all you do to provide leadership to the healthcare industry here in Georgia. And also, as a reminder, be sure to complete our meeting evaluation, which will be emailed to you. Your survey feedback is a great help to us as we continually improve our education programs. If you like something, let us know. If you want something changed, let us know that too. We're constantly updating our programs. Be sure to self-report 1 hour of qualified education credit on the ACHE website, and have a great afternoon. And we hope to see you all again at one of our upcoming events. Have a great week.
Thank you.
Thanks, everyone.
Thank you.
Have a great day.
Thanks, Bruce.
Appreciate it, John Paul. Have a good day.